Okay, so as I mentioned before, this is part of our speaker series, and today we'll be diving into the effects of COVID-19 on health access, especially as relates to medical insurance in the context of Zimbabwe. What is the current state and where do we see it going? So because we are already behind time, I'll quickly allow Dr. Mukonoweshuro to introduce himself, tell us a bit about what he does, and then we can take it up from there. Over to you, Doctor.
Hi, guys. Deepest apologies, I'm late. My name is Dr. Sidney Mukonoweshuro. We run a medical aid scheme called Ultimate Healthcare. And just as I joined the conversation, I could hear you going through some of the problems. And before I go on, please forgive me. Won't be able to use my video. We have a power problem here. Power is out right now, so the picture will be dark. I hope that's okay.
All right, no problem at all.
Okay. So we are running, as you know, only about 6% of the Zimbabwean population is covered under medical aid. That means almost 15 million people have no form of medical aid cover. There's only about 1.3 or 1.4 million people who have some form of medical insurance. And even the ones on medical insurance are not happy with it because, you know, like you were explaining, it's too many shortfalls. It doesn't seem to be working. But you've got to understand why it's not working, and which is what led us to starting Ultramed. So Ultramed is a service provider driven scheme. So what essentially we did is, you must understand the relationship is three-way. There's the funder, which is the medical aid society, there's the doctor, and then there's the client or the patient. So the patient pays the funder with the hope that the day they fall sick, they go and see the doctor and the funder pays. What has happened to this triangle is that trust got broken in the sense that you would pay into the fund and then you come and see your doctor, myself, and then your fund just doesn't pay me. And because it doesn't pay me, the next time you come, I'm going to charge you cash. And that's where shortfalls came from. And the shortfalls have unfortunately become very severe that a lot of people cannot even afford. The medical aid, on the other hand, keeps experiencing ever rising, claims. As a result, they keep increasing the premiums. And that excludes more and more people. So that used to be 10% coverage is now 6% coverage. So we decided, why don't we cut out the middlemen, so to speak? Why don't we mobilize the doctors, the service providers? Since it's the patient who pays and you pay to see the doctor, why don't we remove this third party who is holding on to cash and not paying the service provider? So when people sign up with us, they're signing up directly with the service provider. It's a complicated situation because on the side of the medical aid funders, there's an issue of fraud. And if you may know or may not know that medical aid societies in Zimbabwe are losing close to $180 million every year to fraud by doctors. So we know the fraud that we do to squeeze cash out of the medical aid society. So the medical aid society ends up screaming. And because of that, they up the premiums as well. So essentially, this triangle was supposed to be cemented together by trust. And when times get difficult, trust goes away. And then the whole system just ceases to work. And as a result, people are dying from things they don't need to be dying because they just simply couldn't see the doctor. So we have been operating for about 4 years. And we think that our model allows for more people to sign up because our premiums are very affordable. And we can stretch the dollar more than anyone else can stretch the dollar because you are seeing us directly. And because we have ownership of the fund, there's very little fraud because the fraud comes from the fact that doctors have become impoverished. And as a result, if you have a medical aid that actually pays, because we've got some pretty good ones that pay, we tend to hammer them. If I haven't paid my rent and I see a member of a medical aid that pays well, I'm going to inflate that claim. So you walk in with the flu, which is a viral infection and doesn't need antibiotics. I'm going to hammer you with antibiotics. I'm going to hammer you with drips. I'm going to do an X-ray that I don't need to do. I'm going to need to do an ultrasound scan that I don't need to do, just so that I can claim more money. So this is the biggest challenge that has happened, is that number one, medical insurance is generally too expensive for most people in the country, in Zimbabwe and across the continent. Even in developed countries in Africa, or countries that are doing much better, like South Africa. In South Africa, only 18% of the population is medical aid, leaving out about 44 million people with nothing. Of course, the public health system there is still managing to cope, but it's collapsing very fast. So we feel that the only model that can happen, what we need to do, and I'm glad you guys have this forum, because the problem you're trying to solve is a problem that affects over 900 million people across the continent, where healthcare is simply too expensive. And yet it's supposed to be a human right. So, you have women still dying in labor in 2021 because they couldn't afford an ambulance. They couldn't afford to see a gynecologist who costs $100 consultation. They couldn't afford to do an ultrasound scan, which needs $35 because people don't earn that. People are earning $30 a month or less. So we feel that the model that works is a model that centers around the owners of the service, who are the service providers. You can have different strategies, like what they call the capitation model, where you prepay the doctor. When the doctor already has money, it eliminates the element of desperation, because he can feed his family, he can pay school fees for his children, and then he can see the patients, as many as can come, without having to claim extra. Because the cost of a consultation is really a sunk cost in a sense that we don't need any extra raw materials to a consultation. The knowledge is already in the doctor's head. He just needs to be given his money in time and on time. So what needs to happen, just sort of to give a round of sort of conclusion, we need to reimagine and rethink the concept of medical insurance. Most medical insurance companies were built at a time when, we had a lot of big companies, but most of Africa's economies now are informal. And the current medical aid schemes have got no capacity to actually insure the unbanked and the uninsured, because they don't have bank accounts, they don't have pay slips, they don't have all these things. So we need to start thinking along the lines of mobile, for example. There are more cell phones than toothbrushes in Africa. If we can get people to sign up on their phones and using mobile money, for example, because there's very high mobile money penetration. If people can sign up on their mobile phones, and then if they can be registered to a local family doctor or GP, almost a version called community-based health insurance, where the doctor is prepaid or capitated, and they can always go there whenever they need, on demand, anytime one of their family members is not well. And the premium has got to be low enough so that, the breadwinner can actually add his 5 or 6 dependents. If you say the product is $50, then you multiply that by 6, he now has to pay about $300, and many people here would not afford that. So it's really a question of signing up, because it's a game of numbers. How do we get to sign up more people at a small premium and try to push the volumes? It makes economic sense for the doctor, but the program has got to center around the owners of the service, because those are the ones who lower the premiums and who lower the claims. I hope this makes a little bit of sense, but we are making inroads in that direction. We have already created an integration with the mobile network operators here. And so in the next couple of weeks, we're actually going to launch the first mobile sign-up process, where people can actually, in the informal sector, can actually sign up with our medical aid scheme without needing to be asked for pay slips and all sorts. And the premium is low enough, and we've got over 3,000 doctors whose clinics are virtually empty. They are prepared and ready to actually see these people at a price they can afford, almost like the Indian model. Allow me to end here, because I'm not too sure how much time we have, and I'll wait for any questions.
Thank you so much. That was great insight onto especially how Ultra Med Health has kind of mitigated all the shortfalls with the conventional way that medical insurance has been done before. So if you have questions, you're free to unmute your mic or type it in the chat box, and I'm sure Dr. Mukonoweshuro will be able to respond to them.
Okay, you can go first. It's okay.
Thank you, Brian. Thank you so much, Dr. Mukonoweshuro, for joining us today. My name is Tino Kuretu. I'm one of the board members, and I'm actually the founder of Pora Health. Really excited to have you here. My first question really pertains to, I guess, like an issue that we are very interested in, that is, health inequities or health disparities. So you did mention that one of your innovations kind of like encourages the use of funds as a way to have more people getting access to medical insurance. But I'm not necessarily sure though, looking at maybe rural populations, how are you planning on like maybe helping those people get access to medical insurance, given the fact that their access to, say, mobile phones is not as universal as it is in urban areas?
Yeah, thanks for that question. For starters, you will be shocked how many phones are in the rural areas. You will be absolutely shocked. People have phones, and I think mobile penetration in Zim is actually way over 99%. Sometimes people actually have two phones, and with that sector of people, there are ways of thinking around how they can actually pay for medical insurance. So one of the things we're actually doing is we're actually trying to forge partnerships with global NGOs like World Vision, which have always operated in the rural areas. We are inculcating elements of telemedicine in places that cannot be reached or places that don't have infrastructure, like clinic infrastructure. People have phones. And then the other issue is, they may not have cash, but they've got goats and they've got cows and they've got produce, farm produce. Can we not ask them to give us 150 kgs of maize, and we make a deal with GMB or some millers to liquidate that grain, and the cash then becomes their contribution to the fund, and they can be treated at the local hospital. There's enough mission hospitals in all these rural areas. So there is a way, but and why I'm really happy that you guys are thinking about this, and that you guys are young. You've got to imagine and think about something that hasn't happened before, because we're not going to solve the problem by using the same strategies that have always been used. We've got to think outside the box. So if we can liquidate their farm produce, if we can liquidate their animals, and that becomes their premium, we can then use their phones. We can also tap into their relatives who are in the diaspora. You may or may not know the diaspora is sending $1 billion to Zimbabwe every year. That's a lot of money. And we can find something there to cover the healthcare.
Very well said, Doctor. And I kind of have a follow-up question. This is not necessarily related to what you've just mentioned, and I think that was very well articulated. And I study economics in college, and most of the things you have said, they make a lot of sense, and I can see how they can be implemented, and they can bring the change we need. But my follow-up question basically pertains to something you mentioned about doctors kind of like taking advantage of those gaps or those cracks that are in the system. You mentioned that some doctors, they go on to performing like some unnecessary surgery or performing some unnecessary like medical imaging, such as X-rays, CT scans, and stuff. Could you briefly discuss maybe as a medical doctor about the implications that this has, these acts, I guess, have on the health of our population, and basically the implications that are centered around those things.
Yeah, so allow me to say that it's not just the doctors. So the first offender was the medical aid. The medical aid executives tasted the cash, and the cash was good. And they realized that they could actually get away with not paying doctors for services rendered. And that's where the trust began to break down. Doctors, in turn, trying to survive, started doing what we call over-servicing, which is where you give unnecessary services. It's a very dangerous practice. Strategies. Hello, can you hear me?
Yes, we can.
Yes. So it has now become a very complex problem where you have the doctor on one hand, some doctors, performing what we call fraud, medical insurance fraud. But at the same time, you have got medical aid companies that are choosing to just not pay doctors. Sometimes we go for 2 years, 3 years, and the claim is not paid because some medical aid executive has decided to spend the money. The question now is, how do you bring back trust between the doctor and the funder? And sometimes you can't do that with the old players. You need to create something completely new that puts the service provider at the center of it. You pay the service provider on time, and you ask him not to commit elements of fraud. The fraud is very dangerous because if you're going to get, surgery you don't need, that can actually harm you. And the law in medicine is above all, do no harm. We're not supposed to cause a patient harm because we're trying to make a bit of an extra dollar. But you must understand that doctors then find themselves in a very dire situation where they have become impoverished by medical aid societies.
Thank you so much for that. And I'll let Brian go ahead and ask his question.
Oh, okay. Thank you, Tina. Dr. Mukonoweshuro, so my question is, okay, let me just start by introducing myself. I am Brian Sakala, one of the board members of Pora Health. So the question that I have for you is, recently I've been reading an article which was saying India just started providing medical insurance for mental disorders. Is it something that we are doing locally, or is it something that you are planning to implement here locally, or there are reasons why it's not being implemented here in Zimbabwe?
Do you say medical insurance for psychiatric illness?
Yes, sir.
No, all our medical aid products do cover for psychiatry.
Right.
But what has happened, and you bring a very interesting conversation, because of our cultural beliefs out here in Africa, psychiatry is not treated with the sort of respect it needs to, because there's belief in all sorts of superstitious things like kuroiwa, or it's demons or whatnot. So we actually need to start by conscientizing our people on psychiatric illness, that it's something that actually can be treated, and that medical aid can actually cover that. So all medical aid packages do have psychiatry cover, but many people don't actually use it because when someone develops a psychiatric illness, they usually go to a sangoma somewhere, a nganga somewhere, or a prophet somewhere. But we do have that, but we need to do more.
Oh, all right. Oh, so do you have like the figures and like the most mental disorders that you've been covering?
Come again, sorry.
Okay, so like what are the most mental disorders that you've been covering?
Oh, the whole spectrum, really, from your mood disorders, your bipolar mood disorders, your schizophrenias, to your depressive conditions. I mean, anything psychiatry. It's just that the level of awareness is not that high. So, for example, when someone commits suicide, we tend to think it's demons or, the person is weak and whatnot. So I've personally been on TV, run 2 programs where we have tried to conscientize people about psychiatric illness. You've got patients with dementia, for example, you're over 65s. Your Alzheimer's disease, is very underdiagnosed in our setting. And we tend to just, tie our old people around trees and get some nganga to come or some sangoma to come, and people just need to be more aware that these are conditions that can be treated.
Yes. Okay. Thank you, sir. Thank you, sir. Over to you.
Thank you so much. All right. I think I also had a question. I think you've already touched a bit on that when it comes to the mental aspect of health. What I was going to ask is, beyond the financial constraints with many people not acquiring health insurance, what are some of the health-seeking behaviors within Zimbabwe that you think usually lead people to leave the whole issue of getting medical aid?
Yes, so yeah, we've got, it's a literacy problem, I would say, part of it. The bigger part obviously is affordability. People have just realized that even if you buy medical aid, you're still going to have to pay shortfalls, so it doesn't work. Your biggest problem is your cost of entry. So if you're going to see a GP or a general practitioner, the cost is $20 or $25. And that cost does not include any drugs, does not include anything. It's just the doctor telling you what the problem is. So for most people, $20 is all they have. So then they won't bother coming because they know that they will leave the $20 by the reception, get told what the problem is, get a prescription that needs $40, and get lab tests that need another $40, which they cannot afford. So we are thinking along the lines of what we call single entry price, where if it were possible, can that $20 cover everything? Can it cover drugs? Can it cover x-rays? Can it cover bloods? So that our people can, so it's really a question of affordability. Our people are not very well up and they can't afford it. So as a result, they don't bother coming. And so they will stay at home and keep their cancer, and it grows and grows and grows. And by the time they come to see the doctor, it's too late. So if we can fix the access problem, make seeing the doctor a bit more accessible, make it democratized, make it as simple as buying a loaf of bread, then people are going to present early. Conditions are easier to treat when people present early. And that way the overall health status of the population improves.
Okay. So would you also say that something we also need to advocate for those who would be in a position is for people to go for routine checkups, because most only go to see the doctor when there's something that's absolutely wrong. We don't get a lot of people just going for a regular checkup. Is that something that could also improve medical aid access?
Exactly. In fact, you've really hit the nail, on the head. That you have just said is actually one of the reasons people don't buy medical aid, because medical aid in its current form says you pay money every month and wait for the day you fall sick. And in the event that you don't fall sick for 5 years, your money just disappears, because medical aid is short-term insurance, which on the 31st of December every year, it lapses, it just disappears. So if people could reap a wellness benefit, and this is something we've done at Ultimate, we don't wait for you to fall sick. We ask people to come in at least once or twice a year for a general medical. Let's look at your weight and what are the likely conditions you're going to develop in the next 3-4 years. Let's look at your smoking habits. Let's talk about your BP. Let's check it. Most people have never checked their BP, something as simple as that. And hypertension is the biggest non-cause of sudden death, within our population. Strokes being caused by BP, which could have been detected by a test that costs less than 30 cents to do. So we need more people to to come in for general checkups. And if people can see this benefit, then they are more willing to pay because they're not waiting for the day they fall sick.
True. Thank you so much. I think you've really shed light on a lot of issues to do with medical aid access. I don't think there are any more questions. So I would like to hand over to Tonderai to give us the closing remarks.
Thank you. My name is Tonderai Choto, and I'm an associate here at Pora Health. So first of all, I'd like to thank you, Dr. Mukonoweshuro, for an amazing presentation. You really shed some light. There's a lot of issues that you raised. All of it makes sense, and I think we've all learned so much from this. Thank you so much for your time, your effort, and everything that you did in preparing this presentation. I would also like to thank everybody who showed up. We thank you all so much for your time, and hopefully we'll be seeing you more as our speaker series goes on and learning more from this series and finding ways to help people in Zimbabwe and improving the way of life. Thank you.
Thank you very much.